Thank you. I'd like to thank SAGES for the privilege of the podium and the moderators for the introduction. These are my disclosures, which have no bearing on the talk today. As a background, gastroparesis is a chronic syndrome where there's enteral hypomobility and disorders of contractions that results in delayed emptying of solid without any mechanical obstruction. It's becoming more prevalent, probably because we're better in diagnosing it, and is present in up to 50% of the diabetic patients. The treatment is challenging, and there's certainly no consensus for the non-responders of medical and dietary treatments when it comes to surgical interventions. And we do know that electrical stimulators has up to a 60% symptoms improvement, and on the other hand, pyloromyotomy improves subjectively the gastric emptying. This is one of the many pathways that have been described in the literature how to handle this difficult patient population. And once a patient will fail the dietary modifications and the pharmacologic treatments and nutritional support, obviously we go into the surgical interventions that spans from gastric stimulators, gastrectomy, J-tubes, G-tubes, and obviously pyloromyotomy. Our objective was to look at the short and long-term outcomes of a simultaneous gastric stimulator implantation and pyloromyotomy and compare to a group that did not have a pyloromyotomy. Our primary outcome was the success rate, which was defined for this particular study as the lack of ray intervention in these patients. In a period of 20 years that we've been doing gastric stimulator, we ended up with 134 patients. And 2 were excluded since they already had a previous pyloromyotomy. 40 of the patients, or 30%, had a gastric stimulator with the pyloromyotomy, since this has been introduced later on in our practice, whereas the bulk of the patients, 70%, had a gastric stimulator without a pyloromyotomy. Our median follow-up was 46 months. When we look at the demographics of these patient populations, as expected, the vast majority were women in both groups, and as far as the etiology, in light with the current literature, there was a combination of idiopathic and diabetic being the most common etiologies. The only difference between the groups was the opioids, which was more prominent in the gastric stimulator with pyloromyotomy. As far as the outcomes, again, comorbidities were non-different, not different between the 2 groups. Previous history of Botox injection was also not different between 2 groups, and that's usually one on our pathway. Patients end up having a test Botox injection prior to commit to a pyloromyotomy, which is obviously non-reversible. Pyloric dilatations are very rarely used in these patients. As far as the actual variables of the postoperative results, as you can see, none of the measured outcomes were different. That includes readmissions, length of stay, overall complications, including infectious complications, which of course is one of the concerns when we implant a gastric stimulator in a setting of a clean contaminated procedure. Bleeding, hematoma, pneumonia, and so forth. As far as reoperation, there were 2 patients that were reoperated in the group of gastric stimulation without pyloromyotomy, and there was 1 mortality in the same group, which was unrelated to the procedure itself. Looking at the results, the success rate was higher, 82% at 5 years in the group in which pyloromyotomy and gastric stimulator were implanted, as opposed to only gastric stimulator. And when we do a subgroup analysis and looking at gastroparesis and gastroparesis due to diabetes and gastroparesis due to idiopathic causes, the pyloromyotomy group is superior, and in the case of diabetic gastroparesis, the results are significantly better than only gastric stimulation implantation. So in conclusion, pyloromyotomy during gastric stimulator implantation for gastroparesis is safe, It carries a similar postoperative morbidity, length of stay, a long-term success rate, and seems to be more advantageous in patients with diabetic gastroparesis. Happy to answer any questions.